Excuse me, everyone. We now have our speakers in conference. Please be aware that each of your lines is in a listen-only mode. At the conclusion of the presentation, we will open the floor for questions. At that time, instruction will be given as to the procedure to follow if you would like to ask a question. You may also submit your questions electronically at any time by using the discussion area located on the left-hand side of your web interface. I would now like to turn today's conference over to Jen Braun. Ms. Braun, please begin.
Thank you, Jennifer, and hello, everyone. Thank you for joining us for our monthly TeamSTEPPS webinar. This is our December webinar, and today we are talking about team training in healthcare and TeamSTEPPS at Johns Hopkins. We just have a couple of acknowledgments today to start off this webinar. We would like to thank the Agency for Healthcare Research and Quality, otherwise known as AHRQ, and in particular Jim Battles, who funds all of this work for the national implementation of TeamSTEPPS. We'd also like to thank Heidi King and the Department of Defense. They've always been great partners with AHRQ since the start of TeamSTEPPS. And a little bit about ourselves, the project team. My name is Jen, and I'm with the Health Research and Educational Trust, otherwise known as AHRQ. So we are the nonprofit research branch of the American Hospital Association. Barb Edson is our project director, along with Chris Hund, who's the project manager for the national implementation of TeamSTEPPS. And we would also like to thank David Baker and his team over at Impact International, who are partners with us and are very integral to all of the TeamSTEPPS work we do. Just a few pieces of information about the TeamSTEPPS program in general. We offer a 2-day in-person master training course, which is the train-the-trainer approach with the goal of having a team of 3 individuals attend one of our training centers, and they learn the principles and tools of TeamSTEPPS, how to coach, measure, and then implement to take back to their organization to teach others. So we have the training dates posted for 2014 on our TeamSTEPPS website, which is www.teamstepsportal.org. So this year we're releasing the training in phases. So as of now, all of the trainings in phase 1, which is January through March, are full, but we will be opening up registration for phase 2 trainings that are in April through June. Those will open January 13th, so stay tuned for that. So some upcoming TeamSTEPPS events. As usual, we have our monthly webinars that are always on the second Wednesday of every month at this time. We're actually switching over to a teleconference format beginning in January. So beginning then, there will be no web component. But the next one will be on Wednesday, January 8th, about the evidence surrounding team training and TeamSTEPPS. Registration for this and additional information can be found on our website. And on to the next point, we have very exciting news. We're happy to announce that our annual conference will take place June 11th and 12th in Minneapolis, Minnesota, so mark your calendars and save the date. We just released a call for presenters and posters. The form and all of that information can be found on the home page of our website, teamstepsportal.org. And the due date for the call for presenters is Friday, January 10th. So if you wish to present or share a poster, please go check that out. We will open registration for the conference in February. So we're really looking forward to that and hope you can join us. As always, we have a helpline that you can contact us by, as well as our email address, which is arcteamsteps@aha.org. These resources are available for you to come and ask any question you have about how to register, questions on content, or how to connect with others. And so just some rules of engagement for today. The way we like to do question and answer is for you to utilize the discussion area on the left side of your screen. That's where we would like you to type in any questions throughout the presentation. Many times others have the same questions, so we can just look at them and put them together at the end for our speakers. So if and when we've exhausted that list, we will go ahead and open your phone line so you can ask additional questions to the speakers themselves. So today's webinar presenters are Drs. Michael Rosen and Sallie Weaver. Both are with the Armstrong Institute for Patient Safety and Quality at Johns Hopkins University School of Medicine. So we're very happy to have them present today. So with that, I will go ahead and pass it over to you, Dr. Weaver.
Thank you so much, Jen, and thank you so much, everyone, for joining us this afternoon. I'm so excited to be here and have the opportunity to share a little bit about some of the work that we've been doing looking at team training throughout the peer-reviewed literature, and then also be here today with Mike to share a little bit of what we're doing here at Johns Hopkins in terms of developing our cadre of TeamSTEPPS master trainers. So with that, just a few quick points about the goals of our webinar today. First, we'll provide a brief review of the current state of team training in the healthcare literature, talk a little bit about TeamSTEPPS' role in the current state of team training, and share a few examples of implementation of how we've handled this here at Johns Hopkins. So with that, let's talk a little bit in the beginning here about team training science, kind of where are we now? Just a quick bit of information. I do have some disclosures. Portions of my work are funded by AHRQ, the Hopkins Institute for Clinical Translational Research, the Veterans Administration, and the VHA Foundation, but I don't have any other relationships to disclose. So as we get started here in this first section, I just want to put forward a thought question that I hope those folks that are on the line and are participating on the webinar will kind of keep in mind as we go through today's discussion, and that is, how are you integrating elements of what we know from the science of team training into your implementation of TeamSTEPPS in your organization? Or how might you be planning to if you haven't embarked on that implementation piece quite yet? As we go through, I hope that you'll be kind of keeping this question in mind and really thinking through, so at the end we may be able to have some meaningful questions or meaningful discussion related to this point. So with that, I just want to share a brief view. This is one of my favorite quotes by William Mayo. It was given at a commencement speech at Rush Medical College. It might be familiar to some folks that are tuning in. But the quote says, "It has become necessary to develop medicine as a cooperative science, the clinician, the specialist, and the laboratory workers uniting for the good of the patient, each assisting in elucidation of the problem at hand, and each dependent on each other for support." Now, this is a quote that goes back and dates back to 1910. Now, if you look at the most recent literature surrounding evidence-based patient safety practice, I'm incredibly excited to report that here in 2013, in a recent piece published in the Annals of Internal Medicine, several of safety and quality announced the top patient safety strategies that are ready for adoption now. And here in 2013, team training finally makes the list. Now think about that. It's gone from 1910 to 2013. What is that, about 100 years? So it does take time to make meaningful change, but we are making progress, and I'm so happy to report that team training is on the list based on the evidence, meaning that now we have enough empirical evidence to really demonstrate that team training can have meaningful effects. One of the myths that actually surprises people when we talk about this is this idea that if people accept the need to adopt a particular practice, this idea that implementation should occur non-problematically, right? We know it's the right thing to do. We know that it's the right time to do something, so we sometimes implicitly assume that it will happen. And when we compare this to kind of the diffusion of other types of changes in healthcare, I love this piece that was done looking at the diffusion of laparoscopic technologies. It was in Denmark, but you can look at U.S. charts and see similar trends. But if you look at the diffusion of a piece of technology here, if we look at laparoscopic chole, starting in January 91, by about 2 years later, in January 93, almost 80% of choles were happening laparoscopically. That's 2 years. And if you compare that to what we saw with taking almost 100 years for it to get on that recommended patient safety practice list, you can see that really when we talk about diffusion and we talk about clinical changes, a lot of times that diffusion happens much more quickly than it does with some of our organizational and team building and teamwork development types of interventions. So as we move forward, just want to keep that in mind, that really staying the course is an important piece of making sure that implementation occurs in a meaningful way. Another piece, when we look across the current state of the peer-reviewed literature, is that team training is now no longer being viewed as only an intervention to develop effective teams. Team training is being used as a foundation for a variety of other types of patient safety changes, really viewing it through that lens as a building block to create the effective teams, which will allow team members to do all types of other kinds of improvement work. A good example of this, when we did a recent systematic review, not looking at team training specifically, but looking across all types of different interventions that have been used or developed or couched as really interventions to promote a culture of safety. So we looked at almost 4,000 articles across the peer-reviewed literature and found 33 studies reported in 35 papers that have been published since 2000 in acute care areas. Keep in mind, we were only looking at acute care areas in this particular paper. What we found is that nearly 60% of the interventions that were designed to, quote unquote, promote a culture of safety included some type of team training, which is fantastic because in many ways, if you think about a culture of safety, the key tenets and the key behaviors of effective teams really form the building blocks for what we talk about when we're talking about a culture of safety. In terms of this review, there were other types of interventions, of course, that we found, things like executive walkarounds, so having very salient, clear executive and senior leader engagement, and also this idea of kind of multifaceted interventions. So if you think of culture really having multiple pieces that contribute to it, it makes sense that interventions that also have multiple pieces can be effective in moving culture forward. So when we look specifically at team training as this mechanism to move culture forward, to move patient care and patient safety and patient outcomes forward, we definitely know a few key things. We now have pretty solid evidence to show that team training can improve patient safety, but we know three things matter. We know that the implementation strategy matters, we know that the sustainment and continuous improvement strategy matters, and we know that context matters as well. We had the opportunity to take a somewhat more in-depth look at this in a recent piece that we did in collaboration with a wide range of folks from RAND, University of California at San Francisco, University of Toronto, ECRI, a whole group of folks were involved in this large-scale review, Making Healthcare Safer 2. It's an update and critical analysis of the evidence for patient safety practices across a wide range of contexts. And what we found when we looked specifically at team training, that there was moderate to high quality evidence that systematic team training programs can meaningfully improve a wide range of outcomes, things from care processes, things like use of evidence-based practice and handoffs, efficiency measures, so things like reduced delays in care, reduced decision times, of course, safety outcomes, which many folks on the line are very familiar with, this idea that team training can reduce adverse events with teamwork and communication as related root causes, infection rates, other harms, and as well, not just patient safety outcomes, but provider safety and occupational health outcomes. So things like needle sticks, things like the patient's care experience have also demonstrated to be meaningfully moved thanks to team training interventions. That being said, it's important to take away that what we found when we looked at that, these studies where we were seeing these types of improvements, is that programs that demonstrate such effects shared several characteristics. Now, these may not be new, these may not be surprising to folks on the line, but first and foremost was that the programs that were demonstrating these types of effects were really implemented with a systematic and mindful approach. Now, when you look at kind of the most common methodology, the train-the-trainer model is a very common approach to what is appearing in the peer-reviewed literature, but really this idea of those organizations that did this most successfully really looked at team training in the bigger picture and helped to articulate where does it fit in our broader strategy? Where does team training fit with other initiatives that we are engaged in so that it doesn't become, the traditional flavor of the month or flavor of the quarter that sometimes these types of interventions can seem like or feel like. The other piece of this is that not just looking at strategy, but really making it part of the big picture, using team training as a foundation for other interventions, for other improvement strategies that they wanted to build. They really wove this in as a foundational building block. Of course, we now have rather robust empirical evidence to show that leadership and peer support matters. Now, I know intuitively we know this. We know that it's important to have our leaders visibly and saliently supporting our team training efforts. But now we actually have some pretty strong empirical evidence to show this. There's been some great work done by Catherine Jones and her team at the University of Nebraska Medical Center, and they were actually able to look at the degree to which several kind of organizational and implementation factors moderated the impact of team training in terms of how much it was able to change culture. And what they found was that those teams who had functional error reporting systems, those teams whose leadership actually understood and reinforced the value of teamwork, and those teams who integrated teamwork concepts and really kind of institutionalize them by building them into job descriptions, evaluation and promotion criteria, and other pieces of the organization really reaped the largest benefits from their team training efforts. A piece of that then, of course, speaks to this last bullet, this idea of investing in transfer of training and really using those skills that folks develop or refine in their team training work into daily practice. And of course, we know this can be facilitated through coaching and also implementing things like support tools and reminders and structures that really reinforce good teamwork and make it easy to be a good team member. So looking through those implementation and evaluation studies that really showed the biggest impact. These were kind of the 4 high-level examples of things that they really shared in common. So here at Hopkins, we've really attempted to try to take these ideas and in conjunction with learning from a great deal of many other institutions that have done this incredibly well, have tried to formulate this into a strategy that we're implementing here. And it's my pleasure to turn the floor over to Dr. Michael Rosen, who can share some more about what that has looked like from here at Hopkins.
Thanks, Sallie. And as Sallie just said, the next block of this is really going to be talking about how we've learned those lessons kind of the hard way that are now present in the literature that may not have been there, 10 years ago, but talking about how we're trying to make use of that in moving forward. So we're going to share a little bit about kind of the history of what we've done, a little bit about why some of the things we've done have not worked well, and about what we're doing now that we believe, that we have much more confidence in, is going to work well over the long term, like in a sustainable way, in a way that's integrated with an entire kind of safety and quality infrastructure too. So thinking about where team training fits as a part of the big picture for safety and quality improvement in an organization. So with that, we'll talk a little bit about an abbreviated timeline of some of the team training efforts that have gone on at Johns Hopkins over the last 10 or 15 years. And these are by no means everything that happened, but there's some of key landmarks in a few ways. And it starts in the early 2000s. We were attempting to be a little bit ahead of the curve, and we got a lot of buy-in for the idea of implementing team training in all of surgical services. And this was a time before TeamSTEPPS. There were other healthcare team training programs, but, and again, this was before my time, so I will not take credit or blame for what happened in this early bit. But what happened is the entire surgical services were shut down, mandatory attendance for surgeons, anesthesiologists, surgical nursing, and technicians to attend a session basically put on by international experts in aviation CRM. And for those of you kind of intimately familiar with TeamSTEPPS is based on kind of best practices now in healthcare. It's evolved to be its own thing, but it really has its roots in this crew resource management training from aviation and other kind of high-risk domains, the military and so forth. Unfortunately, this effort was a complete and total unmitigated failure. It was a bit of a disaster, actually, and it kind of soured the organization for attempting more team training efforts. Basically, what happened, everyone was together in this large auditorium session, as there were these aviation people were beginning their presentation, and it came across very much like it was perceived as outsiders telling us what to do. It wasn't contextualized for healthcare. It wasn't owned by healthcare workers. It was something being imposed on the professionals in surgical services areas. And, of course, that was reacted to negatively. And there's a lot of learning in there. After the fact seems very, very obvious. Before, best intentions did not play out. So the big lesson, which drives a lot of what we do, not just in team training here, but in all safety and quality, is that idea of ownership, something being done with frontline providers and not to them. That's a critical piece of success, and that we'll talk about more, balancing if we want a systematic approach to implementing TeamSTEPPS in a sustainable way. How do you balance? There's a tension there between imposing requirements on people and having it be something that's owned and people feel engaged and empowered to do. So, first experience, big scale experience here at Hopkins, not a success. But however, in 2004, we were a part of the Med Teams, which is a precursor to TeamSTEPPS, very similar content. We were a part of an evaluation study for med teams in obstetrics. We were actually a part of the control wing of the study. And so the experimental condition implemented med teams, I think, in 2002 and 3 after the study ended. They came here and trained. And in obstetrics, they have been implementing med teams for almost 10 years now. That program is still alive and well. And you think about the difference between, well, what happened? We couldn't even get people to stay in the room in surgical services initially, but obstetrics took this similar content, very similar, just not contextualized differently, and they've grabbed onto it and they've held onto it long after that program has disappeared, really, from everywhere else. So what's the difference there? And we think it is that bit of ownership in how it was implemented and how it came out. In between that time in 2004 and the rest of the organization, we have an experience probably like many other organizations, or at least academic medical centers. Lots of different tools and training programs have been implemented in lots of different units for lots of different reasons. Some of it's reactive. Communication failure happens and it gets implemented. Some of it is very proactive. It gets implemented into undergraduate, graduate medical education, nursing education, things of that nature. Much of it is not training per se, but communication tools, things like daily goals forms, handoff protocols, briefings and debriefings. All of those types of things go in different places. Some of them flourish and stick around for many, many years and have great impact. Some of them don't. But regardless, it's not a unified approach. It's up to different units to pick what they do and where they go after, but there's no unifying place in that. We don't believe can be really sustainable at the organizational level over time. It's just a little too chaotic. It's not systematic. There's no way to hold people accountable that no matter what they're doing something to improve teamwork and team training. So where we are and what we've been thinking about and doing and acting on for the last few years is trying to come up with an integrated approach to teamwork training. So teamwork training that's not that takes advantage of the other existing infrastructures for improving safety and quality. So how do we get a system as a whole to build the capacity for high-quality care, for safe and reliable care? And that's the tension we struggle with most, which we'll talk about, is how do you balance some local ownership and buy-in, some control, some autonomy, but being able to have that kind of centralized support, centralized resources for folks, as well as some accountability structures to make sure that this actually happens and it actually sticks around. Change happens and it lasts. And then we'll talk about some of our ideas at a high level for how we're doing this. So this next slide is, again, a bit removed from the specifics of team training, but more generally, how do you put a system in place to make folks accountable for and equipped to make change happen, make positive change in an organization happen. And this very kind of high-level parsimonious model we're working with really looks at links across levels of the organization. As Sallie said, one of the major findings from the literature is that leadership support really matters for things like team training interventions, and it matters for other patient safety quality interventions as well. It's the leading facilitator, or conversely, its absence of leadership support is the leading barrier to success of these types of things. And there's good evidence for team training that it matters too. Some really neat studies from the Veterans Administration on this. So our model is that across levels of the organization, very basic things break down that are going to influence how effectively we can put change in place and keep it there. And there's things like accountability and feedback. So are we setting good expectations, clear goals? Are we providing people feedback on those goals? Are we setting consequences for failure and success around those goals? Capacity is how do we prepare people to do the work that they need to do around safety and quality. So for TeamSTEPPS provides a phenomenal resource in giving people a unique skill set that they would not get in their normal development as a professional. Right? What's really interesting is a lot of the people in safety and quality improvement roles are there because they're skilled and competent clinicians. And we know that that's critical, that's important, but it's not enough. Either there's a unique set of skills that they need to do to make change happen, be it team training or anything else. So how do you, one, prepare people for those changes and then for those roles, and then how do you kind of learn from mistakes and learn from positive deviant success as well and integrating that in your system. So informal learning goes in that category as well. And then at the very end, it's kind of time and resources, of course, and that's what we all struggle with. So we can make people accountable by getting their input and setting good goals, communicating those goals, giving feedback on those goals, having good consequences. You can prepare them to do the job, but if you don't give them the bandwidth to do it, then, of course, it's not going to get done. And that's also a challenge with teamwork and team training and making sure they have dedicated resources and time to do this training. So, of course, this is a brief review, though, to think about that big picture again. So how are we putting an overall safety and quality improvement infrastructure in place in our organization that includes accountability and training and learning over time? Where does teamwork fit in there? And, of course, it's a training program. It's called a training program, but it's more than that, right? So there's definitely things people need to know to be a good team player. There's skills, things they need to do, and attitudes. They need to value the importance of teamwork. They need to have mutual trust for one another, those types of things. But also, there are many components, if you're familiar with the curriculum, they're training, but they're also really work process oriented. Things like handoffs, things like briefings and debriefings, those things are really kind of work process engineering. And a lot of that work has to happen a little bit locally, too. So how do we come up with a protocol that makes sense for our patients, that makes sense for our clinician needs, our patient and family needs, all that together. So there's a little bit of customization that has to happen with the tools that are in TeamSTEPPS. So thinking really how are we going to balance that as we implement and roll this program out as a concerted effort across an organization. But, of course, there's lots of other competency domains out there, too. We won't go through this in detail, but lots of people are putting forth models of what does it mean, what are the skills an organization needs to have to be able to produce safe, high-quality care. And that's everything from things like human factors, Lean Six Sigma, patient and family communication and engagement strategies, error disclosure, thinking about systems, people who can understand systems and devise system fixes and understand culture and culture change. All of these types of competencies are out there, and we think that developing teamwork alongside of all of these other ones makes a lot of sense, too. Instead of just implementing team training, implementing this team training as a component of the bigger picture safety and quality infrastructure. So this is a kind of a pass at where we are with thinking through where does teamwork fit within that bigger safety and quality improvement infrastructure. And this is, of course, a thumbnail sketch, a high-level outline of some of the different target audiences we're thinking of as we roll this out. And the kind of bottom of the pyramid there are patients, people participating in patient safety and quality on a daily basis. So this is really what are the things that everyone in the organization needs to know. If you're taking care of patients or if you're in administrative positions, there are some basics that everyone needs to know. The next step up, maybe if you're leading a small department or a unit, and you're someone who has responsibility with actually implementing change or improving safety and quality, that's a different skill set that requires some different resources to develop for people. And then, of course, at the highest level, are you implementing and doing large-scale evaluation? If you're a part of the hospital system at the highest level or a large department, again, there may be more advanced skills that you need around some competency domains. So for us, this low level of the organization, and again, we're a few years into this, so we have a lot to learn, and there are folks that are doing this that have a lot more experience in this too, so we're learning from everyone we can. But for us, defining these kind of core things at the lowest level of the organization, everyone needs to understand how safety is a property of systems. Teamwork plays right into that in terms of understanding the human component of those systems and how we're all interdependent in this. Understanding principles of safe design and how those safe design principles relate to teamwork as well as technical work. So developing error-proof strategies and other types of mechanisms into how we work together as a team, double checks and things like that, apply equally well to communication as they do to implementing a specific protocol. And of course, we also believe strongly that diverse input into decision-making process is critical. Teamwork and TeamSTEPPS helps immensely with that, and appreciating the importance of teamwork and practicing the habits of effective team members. Essentially, being a good team member at this lowest level of the organization is what it's about relative to TeamSTEPPS. So these are the recipients of the communication, leadership, situation monitoring, mutual support skills, and we'll talk a little bit more about how we implement those. But kind of a level up at the 2 level, so someone maybe leading change in small departments or units, they need a different skill set too, right? So they need to be able to create and sustain kind of patient safety culture locally, because we know that that's local. So developing one of those that has patient-centered care as its kind of linchpin, using systems-based approaches to identify and reduce defects, all of those types of things. These people really need to lead teams. They need to coach teams. They're the people who are really role modeling and facilitating good teamwork at the local level. So these are people who may be managing conflict and setting those standards for what is effective and appropriate professional behavior for doing that. And we have, for people at this level, we internally have a program that develops all of these different skills. So we talk about developing at an introductory level Lean Six Sigma interventions. We talk about that right next to teamwork principles and how you manage teams and how you pull together a CUSP team. And for those unfamiliar, that's a structure we use here for our unit-based safety improvement teams, and teamwork is a critical component of that as well. So for our kind of people in this kind of mid-management level with safety and quality, there's a skill set that integrates all of the change management for technical work with teamwork as well. And then at the higher levels of the organization, kind of between the 2s and the 3s area, there's a larger set of skills. And this really, to master everything you need to master to be at this level of doing good evaluations, you really need basically the equivalent of a master's degree in program evaluation. You may need Lean Six Sigma black belts. This is where we envision and are targeting our TeamSTEPPS master trainers to live, and of course advanced human factors and engineering skills. These may not all live within one person, to be clear. This is just the skill set you need if you're going to be a larger department within the hospital level, the folks who are at that level. So that is our kind of learning and development infrastructure, and hopefully it's going to be a little bit clear on how we're thinking of integrating TeamSTEPPS with all the other skills that need to be developed. We think TeamSTEPPS is a great program. We think it's a very powerful way to build those teamwork and team training skills with people, and it really is becoming the industry standard. So it's what we've built into our program. Of course, we've kind of made it our own. We've integrated it into a bigger picture infrastructure, so it's not a standalone thing. We're not rolling out TeamSTEPPS because as a program, programs tend to have shelf lives. They kind of die and fizzle as the organization moves on to something else. But if we can bake it into just the the organizational structure we set up for dealing with safety issues and quality of care issues, then we feel we have a much better chance of sustaining that implementation over the long haul, and we don't have that hit or miss strategy that we, and I think a lot of organizations have been working under previously. Different units take it, implement it, do very well. Others may not. It's a little bit more unified structure. So in the following slide, we're going to talk about that's the structure we're trying to put in place. People at different levels of the organization, targeting them with very different skill sets. But how do you make people accountable for that? How do you actually make that happen? And there's a couple of different approaches, right? You can hold people accountable, whether it be at the unit level, whether it be at the kind of department, larger department level, in terms of being accountable for aspects of the structure that they put in place, or aspects of the processes around TeamSTEPPS. And that was a little trickier, but we'll talk about an example of how we're doing that here. So structural approaches are pretty straightforward. Things like, do you have the right people in the right place with the right skills? So if you're a large department, do you have a team of master trainers? Do you have enough of them to support the training needs of your organization? How many master trainers per frontline staff do you have? Do you have some way to reserve kind of dedicated training time for TeamSTEPPS, and how frequently is that? You know, what proportion of your staff have gone through TeamSTEPPS training, or at least some components of it? And do you have TeamSTEPPS as a part of your integrated orientation program for people? That's been one of the strengths of the med teams in our obstetrics area that's been able to sustain for almost 10 years now, is it's required continuing training. So new hires go through this training program, but so does everyone else on a regular basis. At least yearly, they go through a retraining program where they get to work through these same teamwork concepts again, and that's what we think is a big piece of their success. But now, having those structures in place is great, that's nice, but how do you make sure people are actually using these skills on the job? Are they actually transferring training, as Sallie mentioned? And there's a lot of factors that go into determining how much of the skills presented in a training program actually get carried over into the work environment. And there's a whole literature on things to do that. We won't get into it too much. But holding people accountable, giving them feedback is one of the good ones to do that, one of the strong ones. And it's tricky to do with TeamSTEPPS because, of course, no one's going to elect to be or volunteer to be held accountable for something where there's not a measure that they feel comfortable in or that they feel is of high quality. And similarly, if that metric is imposed on someone, they're held accountable to something where they don't believe the metric is valid, they're not going to feel very good about that, and that's a problem. So that's a challenge in TeamSTEPPS because a lot of you have two sources basically of measurement for teamwork, some type of observational measurement or some types of self-report. Each of those kind of have challenges. We'll talk about one unit that they have elected to hold themselves accountable to a TeamSTEPPS process measure, which we were very excited about, and we'll talk about what that is right now. So this is in one of our surgical departments, a large one. They recently developed their own set of TeamSTEPPS master trainers. They're implementing. They're doing phenomenally well. And in terms of our kind of quality goal-setting scheme, there are some standard goals that we're all held accountable to across the board. Then there's kind of 4 unique ones for any given department that they set themselves, and 2 are pretty much kind of sustainment goals, and 2 are improvement goals. And as they're implementing this, they chose one of their improvement goals to be around the briefing and debriefing quality. Now, we all know that there's documentation on preoperative briefing, as it's a regulatory requirement. We also know that that's turned into a bit of just an administrative check the box, and there's not a lot of value most of the time in most places what goes on, and just because it gets called a pre-op briefing doesn't mean that anything happened. So we have a very simple tool that we developed. One of the problems with observational tools is that they can become burdensome to train first you have to have people to go out and collect the data, but then you have to train people to collect that data reliably. But this is a very, very simple tool. It captures a very thin slice of teamwork, so we're not asking people to rate globally, so there's a lot more validity to it. And basically, it captures 3 dimensions around briefing quality. Are people showing up? So are people present? Are people paying attention? And we capture that through, are they pausing other tasks that they're doing and actually focusing on the briefing? And are they speaking up and contributing anything? And the bar for that is, do they say anything during this briefing? So it's a relatively low bar, but we found a lot of great data. And in a lot of the data we've collected around our system, there's a lot of room to improve just these very, very fundamental things across the board. Some people do it exceptionally well. Some people don't. And the median there is towards the lower, so there's a lot of room for improvement. And if you want more details on this tool, it's available online now. It's a published tool. But anyway, so folks have elected to hold themselves accountable for this, and in that accountability structure, things like bonuses are tied to how well they perform on this. So it's a huge, we think, advantage to tie as much as we can and being creative as we can to come up with very practical ways of measuring teamwork processes and tying those into the accountability structures that we have in our organization. So in summary, how we're thinking of implementing TeamSTEPPS, and again, we've been implementing TeamSTEPPS for a long time, and we've probably fallen into the trap many folks have in talking to folks and who I hear is that we know that culture is local. We know that local ownership is necessary for people to take this seriously and implement and sustain it. But if all the effort and energy is doing it unit by unit by unit by area, then we're losing the benefits of having a centralized structure for managing this, a centralized structure for distributing these knowledges and skills and holding people accountable for those over time. It can't just be purely bottom-up, or it's going to fizzle as soon as those people who've elected to do that and engage in TeamSTEPPS move on. So we're thinking about how do we build TeamSTEPPS capacity largely in the organization, and what we've done is tied that to the rest of our the competencies we've identified as necessary for safety and quality improvement, and try to integrate those and try to introduce these concepts in many different places for different people, but specifically targeting, based on your role in the organization, what aspect of this is relevant for you. And working on building accountability structures, initially we focus mostly on the structural things. Do people have the right pieces in place? Do they have the right, do they have a team of master trainers in place? Are they conducting training sessions? Those types of things. We're moving towards, as we get better and better with practical tools for measurement, holding people accountable for the TeamSTEPPS behaviors to aid in that transfer of training piece. And the big kind of not unanswered question, but really one of the tougher ones in safety and quality in general, that's the case, but in team training follows right along with that, is how do we allocate time and resources most effectively to make this work? And that's, we'd love to hear everyone else's input on that too. We have, some ideas, but they're by no means evidence-based, so we would love to know what other people are doing too around how do you make good decisions about allocating enough bandwidth and capacity for people to participate in this, and how much is enough. And with that, I think I will turn it over to Jen.
Great, thank you. Oh, sorry, Alexis, go ahead.
That's okay. This is Alexis Higbee from Impact International. I want to thank you very much for the presentation. I really enjoyed your presentation, and I'm sure everyone on the phone appreciated it as well. I think one of the things that this presentation really supports is the idea that TeamSTEPPS or any team training needs to be, as Sallie put it, woven into the fabric of the organization. And thank you, Mike, for giving us a detailed picture of team training at Johns Hopkins. I'm sure that this will be very useful to our TeamSTEPPS community. We've been monitoring the message board and doing our best to answer questions in real time, but we do have some time left, and I have a number of questions from the audience for you too. Just so everybody knows in the audience, if we do not get to your question, answers will be posted on the TeamSTEPPS portal for any questions that we do not have the opportunity to have Drs. Weaver and Rosen answer in real time. So on that note, I have a list of questions here for you too. Are you ready?
Absolutely.
Okay.
Absolutely.
So I'm going to go in order of how we received them. The first one is a two-part question. A participant would like to obtain evidence showing how TeamSTEPPS improves outcomes and efficiency for surgical platform. This is to help convince the surgeons that TeamSTEPPS is a good method. Do you have any recommendations of best places to look for this research? And the second part of the question is, how have you attempted to engage physicians in their buy-in?
That's great. So I can take this one. So to part one, Sallie and I actually just wrote a review a few years ago of all the evidence around team training effectiveness in healthcare. And so part of the last AHRQ compendium, there's a chapter in there on teamwork training that is pretty up to date. It may miss stuff in the last year or so, but surgical services is where there's absolutely the most evidence that this matters quite a bit. Impacts on, of course, patient outcomes, mortality, morbidity, complication rates, as well as process, things like room turnover times, error rates, all those types of things. Lots and lots of strong evidence there. Maybe we could post that chapter along with some of the responses. Is that possible? Alexis?
Sorry, say that again?
Is it possible to post the chapter or the link to that chapter?
Oh,
okay.
Absolutely.
Great.
Okay, thanks. Go ahead.
No, go ahead.
I was going to go on to the next question. Are you ready?
Sure. I think there's a part two that I forgot, though, but that's the how do we engage
Yeah.
So, that's a great question, and it's, I think, about finding the right folks. I think with that evidence, there's a lot of compelling stuff there, too, and I think data always is a huge, great engagement factor. So knowing that it's good for people's patients helps a lot, and now that we have the benefit of having a lot of the evidence, I think so, that's pretty much what you would lead with. But there are also a lot of other good reasons to participate in this as well. Being an academic medical center ourselves, we propose this as a research opportunity too. We propose it as an education opportunity as well for resident programs, for undergraduate medical education and nursing. It's a way to fulfill requirements that are already on top of them that may not have a clear answer, things like systems-based practice, things like interprofessional communication. It's presenting as a solution to problems they already have versus here's another thing for you to do goes a long way.
Wonderful.
And this is Sallie. Just if I could just add one quick piece to that, Alexis, there's also been some other relatively strong systematic reviews that have been done in the British Journal of Surgery by Ken Ketchpool and others at Oxford, and a couple of others that have appeared in BMJ that also look specifically at surgery in particular. And in terms of engaging our surgeons and our physicians, I think one of the key selling points, just to add to what Mike discussed, is not only talking about the evidence in terms of impact on patient outcomes and things like that, but also impacts on efficiency. Things like throughput, all of those, there's some good evidence to show that effective teams do those things more efficiently. And so that can be one of the kind of avenues also to opening up that door to physicians who may be interested, that there really is some kind of tangible return on investment, really tangible ROI in terms of efficiency and value that they can create by being more effective teams.
Great, thank you. Next question. A few participants were interested in this one. Are you doing any work and research regarding team training in the ambulatory care setting?
So we have not, to my knowledge, in our group, done much in the ambulatory care setting. We've recently stood up our first group of master trainers in the home care area, which I realize is very, very different. And there is a learning curve in adapting to those areas. I believe there's a primary care module for TeamSTEPPS, but I'm not sure if there's a specific like ambulatory surgery, if that's what you're referring to. So we have not done much in that area yet, to my knowledge. Unless, Sallie, you're aware of something I'm not.
No, not from our end. Our home care group is starting. They have gone through a master's trainer training and are in the process of developing kind of their implementation plan. Some of the strongest work I think that's really looked at kind of outpatient or ambulatory settings is some of the work that's been done by, I think it's Craig Bennell and Saul Weingart out of Dana-Farber. They've looked at implementing team training in their, I think it's their outpatient oncology group. That's summarized in a recent paper that just came out in BMJ Quality and Safety, I believe. And I think that might offer some great insights for folks that are looking particularly in the ambulatory setting.
Okay, thank you. The next question was, can you please discuss where the AHRQ-supported work is on adapting TeamSTEPPS for primary care? And I'll just go ahead and answer this one, that the primary care implementation will begin in 2014, and you can stay tuned on that and look at the TeamSTEPPS portal for updates. And on to the next question. Are any members on your team Catholic Health Initiative hospital employees?
I do not believe so.
Okay. Next question. How do you at Johns Hopkins give recognition to individual team members?
It's trying to understand the question. I guess I'm kind of reading that multiple ways. Recognition in terms of at the front line, we're kind of coaching, developing, mentoring people, or recognition at higher levels of the organization. I guess I can maybe speak briefly to each of those since I'm not sure which it is. But so, I mean, the typical ways we do that, there's lots of, well, I guess the easiest answer to that maybe we have an internal kind of Safety Stars program. So we have a safety summit every year where, improvement projects, and as we're getting more and more capacity in this area, we're hoping to have TeamSTEPPS and teamwork be its own area in this patient safety summit, but where folks get to come and present, kind of what they've done. Here's, the problems we've identified, the solutions we've put in place, and the results we've seen internally, locally, and to kind of share that learning across the organization. I know lots of organizations have those types of safety fairs or safety summits that involve sharing, but I think that's one of the primary ways internally we kind of recognize units that have made the effort and have really put some team training interventions into place internally. That's one of the big ways we do that. Sallie, do you have any other ideas?
So at the systems level, we do have the kind of Safety Star program and recognition every year on a kind of annual basis. Units can nominate folks for that across the health system. So it's not just here at Hopkins Hospital, but across all 6 of our acute care and home care entities. So that's a huge deal. So that's not just local recognition, but also system-wide recognition. And really, I mean, from an easy intervention standpoint, our leadership has really tried strategically to be more mindful of giving recognition in very simple ways and by saying thank you and really doing that and making that in and of itself. It sounds silly, it sounds easy, but really being mindful of doing that and thanking people for their participation and thanking them for leading these types of efforts in their work areas can be an incredibly powerful motivator and let folks know that unit managers, senior level leaders are aware of the hard work that they're doing and really appreciate the effort that they're putting forward.
Great, thank you. And I'm continuing in order. A participant is interested in TeamSTEPPS in nursing education. Are there any best practice models available that you know of?
That's a great question, and I'm not sure. So we're working on that in a number of different ways. So we have a patient safety fellowship program that's a part of nurses pursuing their masters, where they do get exposure to and training in TeamSTEPPS concepts. Teamwork's a part of that. And then when they're also a part of improvement projects, so as a part of their kind of fellowship around safety and quality, they're engaged in different types of safety improvement interventions in the hospital system, many of which include components of teamwork or teamwork training. Also, we have here internally an interdisciplinary education council that's working to have more opportunities for training physicians and nurses to be together with other students. And we have one event which we were having in a few weeks now at the beginning of the year that has been going on for a long time. It's a safety intersession where it's a full week where medical students and nursing students get exposed to a broad range of safety and safety improvement related science. And a big part of that are skills labs where they together, as nursing students and medical students, train on TeamSTEPPS behaviors as a part of the undergraduate curriculum. So there are opportunities. I think some places, particularly the Canadian education system, has been leaders in this, and they have very advanced, I think, models of interdisciplinary education that we're still kind of trying to catch up with.
Okay, and one more question. We just have a few more minutes left, so let's be quick, and then we can move on with our day. So the next question is, a participant is interested in using TeamSTEPPS in home healthcare. Does your team or organization have any experience or evidence in this setting?
So we have had one team of master trainers who's trained in the home care environment, and that's really tough, and I think we're working with them. A lot of the concepts resonate with them. You know, it makes sense, this works, but it's a struggle to fit it into their work processes and their work routines. So I don't know of any research, and I could just be missing it, that focuses on home care environments specifically, but we think that absolutely there's a lot to be done there, and there's a lot of benefit to be had by putting that in place. They still do kind of a virtual huddle since everyone's distributed all over time, so we're working on, ways to structure using TeamSTEPPS concepts, that kind of virtual huddle that they do, so everyone can have a little better situational awareness of what's going on. But that one, we're really early on in figuring out, so we're probably in the same boat as you are.
Okay. Well, I'm going to stop there just because we have 1 minute left. And I see we do have other questions, and I appreciate all of your participation. Again, we will get answers to any remaining unanswered questions and post them on the TeamSTEPPS portal. If you're not registered on the TeamSTEPPS portal, please do so. Just go to teamstepsportal.org. It's free and open to anybody who would like to join our group. And, of course, you can also contact AHRQ with any assistance. The email is right here on the screen. And related to this webinar, we have also put together an extensive list of research and evidence-based articles on various related topics that can be found on the TeamSTEPPS portal as well, so please go check it out. And in closing, I want to thank you all who have joined us today. I hope you found it valuable, and if you have any questions, please contact us either at the earlier number that we posted or again at this email address on the screen, and we'll be sure to get back to you. Once again, thank you, Sallie Weaver and Mike Rosen, for the presentation. Thank you to the support of IMPACT and AHRQ, and thank you to the conference service for hosting the call. And this concludes the webinar for today.
Thank you, ladies and gentlemen. This concludes today's teleconference. You may now disconnect.